So I would like to invite my panelists here, which is Dr. Sullivan, Beth Herney, and Gail Bannock. Here, these are yours. Just put it out there. Go with the microphone near. Beth, Gail, that's yours. Yeah. Wait. So far you have heard a lot about law enforcement, how the law enforcement has been intersecting and taking care of it. You heard about in the last panel about the treatment providers, how difficult situation it is. It is a very complex problem. One of those things which I would like to remind you is that it is no different to Dr. Biaggi's point and Dr. Johnson's point that addiction is a disease, and also you're looking into context that not every patient is the same patient. And if you want to compare that from any chronic disease perspective, what happens if you have somebody with diabetes, high blood pressure? There are 2-3 different patients will need through 2 or 3 different modalities. Somebody who could be very grossly overweight, obese, can lose weight, but still might end up requiring medication, may not be able to get off the medication. The similar thing applies in opiate addiction also. You can have opiate maintenance program, which Dr. Biaggi was mentioned, and you can have opiate-free program, which some of those individuals will be, like Dr. Johnson has mentioned. One of those things I would also like to bring it, Sheriff has mentioned Vivitrol. Vivitrol has been upcoming, and it's not only for the incarcerated population. It can be provided by any primary care physician, but you have to certainly go and get educated. At the same time, you have to have a balancing act of behavioral health side by side, because the counseling, family support is very important. So that is something I just wanted to keep, that we have all these options available, and we have a lot of information today. And with that, we would like to say, yes, we have treatment, we are taking care of all these things. But the main question, the million-dollar question is, how can we stop it? How can we prevent it? Because unless we try to do our effort towards it, we will never be able to catch up what we are going. That line which you saw, I showed you some trends, it's continued to rise, and that's what we want to stop it. So I have my panelists here who are Dr. Sullivan. Ross, if you want to stand and do that, that's fine. Whichever way it works, it's pretty much flexibility. Use the pointer. And also we'll start with that what are you seeing? Why are we seeing this problem at this point? Why are we, a lot of times my colleagues, my physician, I used to take care of patients before until a few years ago, and even my colleagues, this is an epidemic brought in by a physician, and it hurts. As a doctor, it hurts me to hear that we could be the problem. But at the same time, the question comes in, how did it become? How did we get where we get it from? So this is something I think, Dr. Sullivan, if you can answer some of those questions, that would be great.
I'm actually going to stand because I can't do this sitting. My name is Ross Sullivan, and as mentioned, I work at the upstate emergency room, where as a toxicologist, I have both the fortune and misfortune to see almost every overdose patient that comes through the door, and my paths cross often with Dr. Johnson as we try to take care of these people. And this is emergency room visits, and this is underrepresentation of what we're seeing. But heroin overdoses in 2015, about 30. And this is a gross underrepresentation, as this is all just what people tell us when they come in. And we also have heroin-related injuries, so people who get in car accidents, or we have a large number of people who get raped or get beat up or are assaulted as a result of using these. So there's quite a few things that can happen as a result of using heroin, not just overdosing on it, as you all know. So how do we get to this point? And unfortunately, as Dr. Gupta said, as physicians, we've contributed to this problem greatly. And we need to figure out a way, as all of us together, to stop this. So as you can see, opioid sales actually equals opioid prescriptions. And in 1999, you can see that opioid sales and opioid deaths were whatever they are on this graph. And over time, through 2011, have exponentially increased. Exponentially. And this is a result of us writing prescriptions. But how did we get to this place? I mean, were we just blindly just going through the woods? And partly yes, but a lot happened to get us to this point. In 1986, this real famous paper came out, and basically they wrote that opioid maintenance therapy can be a safe, more humane alternative to surgery or no treatment. And maybe that's true in some circumstances. But this paper argued that there were no side effects of using opioids chronically. And this was a paper that came out in 1986. Now, in 1990, with the people who wrote that paper behind it, the American Pain Foundation made a recommendation to all of medicine to make pain the 5th vital sign. Now, what are vital signs? Well, as physicians, we monitor vital signs: temperature, heart rate, blood pressure. They wanted to make pain just as important as these things. And in certain circumstances, it absolutely is. But in every circumstance, it's not. And unfortunately, we are mandated to do so. In 2001, the Joint Commission, which is a group of, I don't know, suits and people somewhere, who actually commission our hospitals, they actually give us accreditations. In 2001, they launched the Pain, the 5th Vital Sign campaign, which now made it mandatory for us to treat pain. And not just treat pain, but to make sure that people's pain was almost completely gone. And if that wasn't bad enough, in 2004, the Federation of State Medical Boards, who oversees all of our medical licensing, called in all state boards to make the undertreatment of pain punishable. So as physicians, we've really, over time, have been kind of forced in some way, but also blindly led to the overprescription of opioids. As a result, in 2012, we have written for 260 million prescriptions of opioid pain relievers. That's enough for every American adult to have a bottle of pills. It's a 300% increase since 1999. Unbelievable. Almost 2 million Americans aged 12 or older either abused or are dependent on opioid pain relievers in 2013. And as Dr. Gupta mentioned, about 16,000 people a year will die in this country every year from opioid pain or related injuries. So what are we doing about it now? So myself and Dr. Johnson and other people and physicians, we are making our mission to go out to other hospitals and to clinics and talk to other doctors and residents and students and high schools and everywhere we're going. And we're trying to tell people that opioids are bad. We actually are doing this as much as we possibly can. We know that they can lead to tolerance, withdrawal, and addiction. Other things we tell people. Sometimes kids don't understand those things. We say, by the way, it can lead to severe constipation. They understand that. They don't like that. It can change to a change of personality, a change of behavior. We mentioned earlier that scientifically proven that pain actually increases after several weeks of an opioid. And actually now new research shows, and we're naive to this too, we found that in adolescents or teenagers that are given a prescription for a legitimate reason, a broken arm or a broken leg, they actually have higher rates of addiction later on against kids who don't get those. So think about that. This is not just for us physicians, this is for every parent and friend. When someone goes to the emergency room and you say, oh, my kid has a sore throat, can you give him Lortab? Remember that. That's a very significant point. So we as physicians decided that we should probably start cutting off prescription pain medications. And unfortunately, around the same time that prescription pain medications started becoming decreased for prescriptions, there was an increase in heroin usage. So, well, what can we do? Well, all we can do is try to teach and do prevention, reduction, and reverse. And this is something that we go all over the place to try to teach. One thing that we can do, what we're doing as physicians, is iStop. And I was on one of our local committees for this, and this is now a law. And this stands for Internet System for Tracking Overprescription. So now as physicians, every time we write a prescription for an opioid or any controlled substance, we actually have to look at this website, this database, and it will have every controlled substance prescribed to that person on that website. So we actually have to consult this before we actually write a prescription for somebody. Again, this has seemed to work. We also do initiatives where we go out and we teach physicians and other people how to deal with pain in other ways, as mentioned before. Not to belabor the point, but alternative ways to treat pain. The point is reducing the first time to your first opioid prescription, reducing opioid prescriptions, the first ones. Use non-opioids, Tylenol, Motrin, lidocaine patches. The list is there of other things that you can do. We also use Espert. We're starting this in our hospital soon. We're already doing it in some places. We'll be doing this in our emergency department very shortly as well. Again, just reiterating what we can do as a group, as people, as physicians and people in treatment. Buprenorphine, methadone, this is time to relapse. And we can see that these programs work. This is over 36 months. People who are committed to their programs have a low amount of relapse. But guess what? Even if you don't use medications, if you stick with it over time, just behavioral therapy, even without those things, seem to work. And there's still less relapse, even if you just stick with it. Also, we are doing naloxone prevention program, and you'll be hearing more about this later. And in the back today, SBH is graciously going to be doing some naloxone Narcan training. We do this in our hospital as well. In the emergency department, we've started this program, and to date, we've now given about 45 naloxone packages out to friends and family members of patients who've come in either overdosed or have problems with pain pills or heroin. And that's just in the past 8 months. We've given about 45 of these out. So in conclusion, really together, it's going to take all of us to prevent this. We need to talk to our loved ones about this, about pain and drugs and medications. It's an important conversation to have. For those of you who prescribe or are getting medications, please avoid using that first-time opioid unless completely necessary. Explore alternatives for pain. And as physicians and everyone in this room, we need to join hands with all people in a fight against opioids and heroin. Thank you very much for your time. I appreciate it.
Thank you, Russ. So thank you, Dr. Sullivan, and that was a very well pointed, and I think it highlights the importance of that, how asking the right question when you are going to a doctor, whether it's an emergency room or it's in a private office or anywhere, please ask the question, become an active partner in taking care of yourself. And with that, I will move on to Beth, who is just something I would like to kind of comment on some things and see what, as a prevention network, what do you do if I'm a mother and I am trying to try to find some information, or trying to have some educational thing, what kind of information you can provide, what kind of guidance you can provide to the community members?
Okay, so one of the primary responsibilities at Prevention Network is information and referral and fielding community calls on a daily basis from examples such that you gave. We are able to assist callers in getting to the services that they need by providing information about the services. All of my colleagues that are here tonight, as well as other providers, support services, 12-step groups, you name it, we can help them access and provide information about the services. And if someone calls and wants to know about a service we don't know about, we look it up and we work with them to find out more.
Right. So if you can just go the overview, I think you have a few programs which are very helpful for the community. You want to stand up and talk?
Oh, no.
That you're okay? Just
Thank
giving
you
you
for
an
asking,
option.
but no.
Just giving an option, you know. People they're
appreciate
tired
the
of
option.
sitting probably, so I just wanted to make sure that we are okay.
I'm good.
Great, thanks.
What I truly believe the most important slide I have is the one that's up there in terms of the mission of Prevention Network to implement and support strategies that help address these issues. Really, prevention in a nutshell is about decreasing risk factors and increasing what we call protective factors. And we do that for individuals, we do that for families, and we do that at the community level. And Prevention Network is a part of doing all of that. And it means something different for different people. Education and information referral is a huge part of what we do, but not the only thing that we do. But our primary mission is to help those who are struggling. You might have the addiction itself, you might have other concerns, and we're able to help get you where you need to be.
Yeah, so some of the services I think you had mentioned in the when we had the conversation, that you can really help them. I think especially one of your family support navigator, that sounded very great idea.
Yeah, I'm
so
really
can you talk about that?
Happy to be able to talk about a new position that we have through OASIS funding. OASIS was mentioned earlier, and with their support, we're able to staff a family support navigator, which means that person will now be able to assist families struggling with addiction throughout the entire process, from start to finish. From the minute they're in crisis, they can call, and our staff member will support them in getting all the services, the treatment, the support, the recovery, everything that they need in conjunction with the partners that are all here tonight. Right. It's totally a community solution, but we now have a person dedicated to do that for families on a daily basis.
Right, so if I have some problem and my child, I'm trying to navigate the system, somebody will be able to hold my hand.
Absolutely.
And then walk me through. That is a wonderful thing.
It's very exciting. It hasn't happened before.
It is a very complicated, web, essentially. And how about the Teen Institute and your other environmental prevention?
Part of what we do for young people is we have a peer leadership training program. It's called Teen Institute. It's in schools, it's in community groups. any young person that wants to be involved in it, we'll find a way to get them involved. Other things that we have for young people are Botfin's life skills, again, that we do in schools, we do in community-based organizations that have youth components to them. We can do it in a small group right on site at Prevention Network, or we can come to the site where there's a youth group already gathered.
Right. What are the other, I think you have multiple services, which when we were discussing it that you had it. So can you talk a little bit more?
Yeah, I'm not going with my slides. But,
Right.
So primarily, I mentioned the 2 youth ones. Information referral I mentioned. We have the same list that was up prior. We can get you the phone number to any one of the places that was on the list, as well as private providers and things like that. We have the Victim Impact Panel, Impaired Driver Program. Some of the law enforcement mentioned some of the different things that someone facing a DWI or DWAI need to go through. We are training prevention professionals in the field so that, as Jeremy mentioned with the CASAC training program, training counselors and so forth, we're training folks to do the prevention piece of the work. And we also offer custom-tailored educational presentations to meet the needs of whatever group is asking. We'll talk about substances, we'll talk about risk factors, protective factors, we've talked to physicians about how to incorporate some of the language in the med school, things like that, and we're also working towards changing policy. Part of prevention is looking at changing policy and working with legislators and county officials and law enforcement to create a safer community via policy change.
Right.
And then the final thing I think I have on here is ESPERT. ESPERT was already mentioned, but one of the positions at Prevention Network is a coordinator for all the ESPERT services that you already heard about. Our staff person is just looking at what's already happening in the community and how can we increase that service in addition to what you heard tonight. And we're hopeful that that will increase rapidly the use of ESPERT and the training of people to be able to use ESPERT.
So can you explain what the ESPERT is?
Yes, ESPERT is screening, brief intervention, and referral to treatment. It's a process that starts with a simple screening tool that might indicate there could be a problem, and then the brief intervention, which could be a 5-minute conversation, 10-minute conversation, could be done with the individual. And then if there's more of a need than that, then there's a referral made to treatment. And it's not necessarily a clinical service, so we're looking at having hospitals, crisis centers, critical care centers, Monica mentioned urgent care, things like that, so that everybody it's a universal practice, and everybody should be getting screened just like they are for diabetes and heart disease and things like that.
Right, Robert. That's something I think it's very important, as Dr. Sullivan mentioned and you mentioned, is something I'm working with the medical society also, just try to see whether we can do it on an outpatient basis, because when the person comes if there's a screening right there, it's a pretty simple thing to start it, and it can be very helpful for the doctor to see, and also for a mother or a patient, whoever is coming, to see, oh, maybe there could be a potential problem there, and maybe we shouldn't be using this kind of medication. That sort of cuts that out. To Dr. Sullivan, your point is essentially we are trying to reduce the first prescription of opiate and trying to curb that skyrocketing rates which are going, and that will be very helpful. So this is a very, there's nothing better than prevention.
Right.
So that is good.
And there's just one other thing I wanted to say, and that was that, Dina so eloquently shared earlier her personal situation, and if you're lacking hope or you're lacking strength, call us, because Prevention Network will help you. We'll find the hope, we'll find the strength, and get you where you need to be.
Anything else you want to add on?
No, just I commend everybody for being here tonight. This is an amazing room full of people that care about this topic, and it's activities such as this, and then the follow through and the follow up. It can't be a one and done.
Right.
It has to be a follow up, a continuation. As Congressman Katko indicated, there's another meeting forum tomorrow night in Camillus. Communities coming together to address the problem on a large scale and on a small scale.
Okay. So Gail, as a, I know, I would like to ask your expertise because you work with the Upstate Poison Center. Sometimes when we hear Poison Center, why is it involved? So I think in your capacity, what can you provide, what kind of information you can provide to the community which is here today, and also how are you working with the community?
First of all, I'd like to say thank you to all of you for being here tonight, because it really is a tremendous effort to get here, especially after a hard work day. So thank you for being here. And the better news is I'm the last speaker. So anyway, most of you, I'm sure, think of the Poison Control Center as a place to call when your child gets into bleach or medication or something else. But the reality is that a poison is something that when you take into your body, it can harm you. And that's the general description. So it can be something that you took too much medication. It can be you have taken somebody else's medication. So you can see now where I'm going with this is that drugs and drugs of abuse and misusing drugs, that is a concern of the Poison Control Center. Well, let me tell you a little bit first about the Poison Center. We cover an area of 54 counties in upstate New York, and for those of you who know New York City terminology, that's anything north of Westchester County. And we are responsible for about 7.4 million people. And what do? Our phones are answered 24 hours a day, 365 days a year by registered nurses trained in toxicology. We have both clinical and medical toxicologists available 24 hours to help, especially the emergency department doc who's calling about management of a case that something he may not be familiar with or something is unusual that's going on. And docs like Dr. Sullivan is one of our consultants who helps us with those cases. Additionally, the Poison Center also does a great job of education in the community. Not only do we teach the general public about how to prevent poisonings, we also get out there in all 54 counties and talk about drugs of abuse. We also teach staff in hospitals about what's going on in the community and provide them updates. So all of those things obviously are important, but one of the things I don't think that most people know is that the Poison Center provides data. And to some of our legislators, certainly, and as well as to all legislative bodies, for law enforcement, to whether it's local, state, or federal government. If our data is collected and it's uploaded to the American Association of Poison Control Centers in real time, which means that every 8 minutes our data is going to Washington, D.C., to our home office, and if there are any blips on the screen that are any indicators of something's going on there, wait a minute, something's going on there too. That if the authorities will be notified and precautions will be taken. Let me give you an example of that, something locally. Just a couple of years ago, we had emergency docs calling and saying, whoa, what's going on? We have a lot of patients dying from overdoses of what we believe to be heroin. And it turned out that it was fentanyl-laced heroin. So another very strong narcotic that was in the heroin. And because people were dying, it caught the attention of not only docs, but also of the Poison Control Center. And we were able to notify our health department at that time to let them know what we're hearing, what was going on. They notified authorities throughout the United States, and a bulletin went out, heads up, this is what's going on. So these are the kinds of things that the Poison Center does. It's not just about keeping kids poison safe, right? So if we look at again, getting back to that idea of, data, and I don't want to bore you with any more, but if you can look at our trends, if you can see these statistics, you can see that in all of our 54 counties, which is the purple area, and Onondaga County, you can see that the numbers for both heroin and for opiates have been going up consistently. And I also want to point out something else about our data, is Poison Center is just a piece of the puzzle. Emergency departments are a piece of the puzzle. The naloxone that is being administered, it's a piece of the puzzle. So that's why we're here today, to put all of this together, to give you a better idea, and to give us a better idea, too, of what's really going on. And so the numbers that we see, nobody calls the Poison Center when they're having a good time. Obviously, it's only when we have a problem in an emergency department that a doc is calling and saying, hey, what's going on? How can you help me with the management of this? So our numbers are only a very small piece of the puzzle. You need to know that. But they are important numbers, and they do represent the calls to the Poison Center. So One of the solutions that we came up with is a member of this Onondaga County Drug Task Force was looking at accessibility, availability, utilization. The easier it is to access, the more there's going to be use in all probability, right? It only adds up. So we thought about how can we reduce access and availability, and one of the things we came up with was this idea of this SNAD program, and it's another an acronym. It is sharps, needles, and drug disposal. So what we're hoping to do is have law enforcement will be participating in this program throughout Onondaga County to have med boxes at their sites so that anyone who has drugs that they want to get rid of, expired, unwanted, whatever, you can travel only as far as your local police department to get rid of it. It's a pilot program. It's just starting. It gives you an opportunity to get those meds out of your medicine cabinet, out of your purses, and think about what's going on in your community and how can you as an individual make a difference. And these are the where the boxes are located right now. Hopefully by the end of 2016, we will see them in every police department in Onondaga County. And I want to be able to say that we have collected more drugs than anybody else in the county to get rid of, and that this can be a model for many other counties. But you can make a difference. So please think about where you're going to take those medications, and also know that the DEA has a drug collection event in July and in the fall as well. So those are places you can also dispose of your drugs. But together we can make a difference. I appreciate it. Thank you for listening.
Thank you. Thank you. So thank you, Gail. Thank you, Gail. And to the point of that it's one of the slides which I showed you in the beginning was that 1 in 10 actually high school seniors thought they had access to the medication somehow, and they ended up with so much of a problem because they were using it. And that availability of prescription opiates, which could have been discarded somewhere or shouldn't be there, this is the opportunity to have that. And it's 365 days, and we will encourage people to do that. Do you have any questions?
We do have some questions. Thanks, Dr. Gupta. A number of questions I thought that related to this panel and previous panels. I thought I'd come down here with a mic, and if anyone wants to answer any of these. What about 12-step programs? Hey, nobody talked about AA or NA. What's up with that?
So do you have any question for this panel?
For this panel specifically,
Yeah.
there are a range of things that have been coming in, and I think we're sort of not at the specific panel
Okay.
question. There's
Okay.
a wide range.
So this is for
I'm going to hit a few, and if you guys hold, some of them might be relevant if
Yeah.
anybody wants to hit any of these key ones.
So there's a reason nobody talked about it. It's a somewhat controversial topic in the treatment world today. While there's a lot of anecdotal evidence that AA and NA are very good for people and have helped a lot of people tremendously, we don't have any data to validate that. And as a result, it's very hard to secure resources to support models like that. So what programs like ours do is we encourage people to get connected with that, but we can't use it as a treatment model because it's not a treatment program. That's why. But I would tell you, what I can say to you is that we have a lot of anecdotal evidence to say that the people that are successful in treatment, that also get involved with AA, NA, or other types of, whether they're spiritually based or non, they tend to have better longitudinal outcomes from our experience. That's our experience at SBH.
So one thing I will add to that, actually, even though we are not talking typically about the AA and all, it's just creating a community around it. AA is a support program, and heroin problem has been coming on with such a fierce force at this point, and we are trying to figure it out, how we can put ourselves together as a community. And that is something, how to create a support system that probably should be considered somewhere in a different capacity, but that all, again, talking about the support programs.
Another question that may be relevant to our current panel. We've got Narcan training here. We're trying to put Narcan in a lot of places in a lot of people's hands. What about in the schools? We've got EpiPens and rescue inhalers in schools. Why do we not have Narcan in our schools?
Which one's coming on?
So that's a great question. I think, all things take time and due process, but I would say that within just the past month or two, I've received phone calls from several schools and school nurses. And I'll be honest with you, it didn't dawn on me when we first started the naloxone program at Upstate that we run. I didn't think in a million years that would be an avenue, but it makes so much sense. So that's a great question. That is absolutely something that we are reaching out to do. We have some meetings set up with school nurses and administrations around Central New York over the next several months. And indeed, for those school districts that are very interested, we are also very interested, and we will probably be rolling that out within the next several months.
And also, some of them actually in other counties, there has been a same sort of involvement by the school nurses and their programs by the schools which run actually in Naloxone. Not in our county, but that's something that's happening, which is great.
Another question, a couple of people asked this. One person, a very pointed story, my child just got a prescription for a pain medication. He has a condition that would seem to require something heavier than what I can get over the counter. How do we educate parents to ask the right questions to know what to do in that situation? Is it safe or is it not to have that first opiate use?
That's another great question. That's probably the most difficult question that I get asked, or maybe even asked here today. What we do know is that there are other modalities. First of all, it depends how much pain is okay. I think it is okay to sometimes be in some degree of pain. I think as parents it's probably difficult to see our children have any pain. So that's your first choice, is how much pain am I willing to accept in my child? And that's a hard thing to decide. We do know that in a lot of different studies and things, that when we give people pain pills, we don't tell them what they are, that sometimes combining things like Tylenol and aspirin and Motrin very often do just as well as narcotic pain medications. If you're somebody or have a child who does require chronic, long-term medications for pain, I can tell you sitting here right now that the opioids are the worst choice for you, and do not do it, because of the many reasons that we said today. It is a very difficult thing. You need to talk to your physician about it. And if you don't like the answer your physician gives you, talk to another one, because this is something that not a lot of people know a lot about or will talk about, but long-term opioids are usually always the wrong answer. There's a lot of different things that we can do, from different medicines to ointments to exercises. And if it's somebody who has a specific question here, I would be more than happy to talk to you afterwards about some other things. Please go ahead.
I think, too, that part of the issue for both the questions that were just asked goes back to what Dina talked about in terms of the stigma of this issue. Not everybody is willing to face it and address it, and until we start having those conversations and teach people how to have those conversations, starting with parents and their own physician, and why are you giving this to my child? What does it do? Those kinds of conversations. We aren't gonna eradicate it. So it's about starting that conversation or restarting that conversation. Okay.
We are not able to take any more questions or explore any more questions right now. Please keep them coming. I apologize if we were not able to directly address your question, but we are going to address them in other forums, as I said previously, and the majority of our panel members have agreed to stay after for a bit. So if you were not able to hear your question asked, or if you did not write the question down and want to ask it of one of the panel members, please do so when we're done. Thank you very much for your participation.
Okay, thank you. So far, so far what we have done almost for last couple of hours, we have heard from the experts regarding problem from crisis management, treatment option, and possible prevention strategies. Thank you. I would like to thank my panelists for being here.